These are my disclosures. I would just state that I have played a consulting role to a number of companies developing FLT3 inhibitors and other novel therapeutics for AML, including Astellas that sponsored this research. So just to introduce the topic of relapsed and refractory FLT3-mutated AML. AML is a highly chemotherapy-sensitive disease at initial diagnosis, and a number of patients are cured with that approach or with chemotherapy followed by bone marrow transplant. However, if patients relapse after primary therapy or if they fail to enter a complete remission with frontline therapy, their outcome is dismal. And predictors of who is more likely than one group rather than another to either fail to respond to frontline therapy or more typically relapse after it include mutations in a gene called FLT3, FIMS like tyrosine kinase 3. FLT3 is mutated in approximately a third of patients with AML. The most sinister of the types of mutations is called an internal tandem duplication, or ITD mutation, and that's what's associated with a high rate of relapse, very aggressive disease biology, very rapid tumor doubling times. Often patients' white blood cell count, which is a surrogate marker for their disease, can double within 24 hours. So this is a highly aggressive disease that we unfortunately don't have very good therapeutics to treat in terms of standard approved therapies. Because FLT3 is a tyrosine kinase and it's mutated to activate the kinase in cancer, there's been a lot of study of drugs to target FLT3 and FLT3 inhibitors, several of which I've listed here, including midostaurin, which is approved in combination with chemotherapy, but alone does not induce complete remissions, and quizartinib and sorafenib, which are newer FLT3 inhibitors. Each of these has had issues with toxicity that have been problematic, and quizartinib and sorafenib have been problematic because they've led to either single agent or combination responses, but very short-lived responses due to resistance that's caused by new mutations in FLT3, not at the ITD, but in a second site called a tyrosine kinase domain, or DA35. For a long time, there's been interest in developing a FLT3 inhibitor that would effectively do everything. It would inhibit the target, it would do so potently, it would have single-agent activity, and it would be active against both FLT3 ITD and also the TKD DA35 mutations. So just to provide background on the compound we're studying, called Gilteritinib, or ASP2215. This is a drug that effectively does all of the things I said were desirable in a FLT3 inhibitor. It's active against the two most common types of mutation. It's a potent inhibitor, both in terms of in vitro and also in vivo data, which are shown here from a publication in 2017 showing that at doses that we give clinically, FLT3 is completely inhibited in patient sample plasma. And this is seen consistently amongst patients treated with the drug, and that's associated with single-agent activity in the relapsed and refractory setting, which is shown graphically here. So we set out to compare the activity of gilteritinib, not just in terms of its anti-leukemic response rate, but actually its ability to prolong survival in comparison to standard chemotherapy for FLT3-mutated AML in first relapse or in patients who failed to enter remission and were primary refractory. Eligibility for this study required demonstration of a FLT3 mutation, either an ITD or a TKD mutation at the time of study screening. And patients needed to have centrally confirmed QT in the normal range, less than 450, because other FLT3 inhibitors had had very problematic issues with QT prolongation. Patients were randomized 2-to-1 to either gilteritinib as a single agent or salvage chemotherapy. And the salvage chemotherapy could be whatever the investigator thought was most appropriate for the patient from a list of 4 different chemotherapy regimens, 2 of which were intensive, either mitoxantrone and etoposide cytarabine or FLAG-IDA, which again are very toxic regimens delivered in the hospital and typically with a month-long hospitalization for recuperation and supportive care. Investigators could also choose lower intensity therapies such as azacitidine or low-dose cytarabine that generally are given in the outpatient setting. But the choice had to be made prior to randomization. And once randomized, patients were followed for the primary endpoint of overall survival. Now, as you note, there's a second primary endpoint. This protocol was amended midstream to allow a co-primary endpoint in the gilteritinib arm to demonstrate its efficacy, and this was used for drug approval, but did not change the overall analysis or conduct of the trial. So the trial's primary endpoint is what I am showing you now in terms of the final endpoint of overall survival, and this is the first time we've presented these data to the public. Patients that were randomized on this study to gilteritinib could go to, either arm could go to transplant. Patients randomized to gilteritinib could resume gilteritinib after transplant, but there was no crossover. So patients having relapsed on the salvage chemotherapy arm could not receive gilteritinib thereafter. Baseline characteristics showed that the median age was 62. Primarily, these are patients with intermediate risk karyotype, and 90% had a FLT3 ITD mutation. About 20% of patients had had prior transplant, and over 80% of patients had had intensive chemotherapy as frontline therapy. There was about a 61 to 39% relapse to refractory split amongst the patients, and the prior therapies are shown here. Response rates for nearly all effectively all defined protocol-defined endpoints were more than doubled by gilteritinib therapy, with the CR rate of 21% in the gilteritinib arm and the chemotherapy rate of 11%. The combined CR and CRh rates were 34% and 15%. And the duration of remissions achieved with gilteritinib were substantially longer than those in the chemotherapy arm, with 11 months of median duration of CR or CRh, which is a CR with partial hematologic recovery, versus only 1.8 months in the chemo arm. The duration of therapy was also substantially longer in the gilteritinib arm, at between 4 and 5 times longer for gilteritinib. Remember this as you're looking at toxicity data. It's hard to make a comparison when there's much more exposure time to gilteritinib. So when I show you toxicity data, that's just going to be for the amount of time that basically patients took chemotherapy, which was approximately a month. And transplant rates were higher in the gilteritinib arm also. This is important because relapsed and refractory patients generally are not cured unless they go on to receive a transplant. The overall survival, which is the primary endpoint, is shown here, which was statistically significantly better in the gilteritinib arm, with a 36% reduction in the hazard risk of death associated with gilteritinib therapy. The median overall survival was 9.3 months for gilteritinib and 5.6 months for salvage chemotherapy. And the one-year survivals were 37% in the gilteritinib arm and 17% in the chemotherapy arms. Toxicity in the first 30 days of therapy are shown here with gilteritinib in green and chemotherapy in gray. There were some toxicities that were more common in the gilteritinib arm, such as LFT abnormalities that were generally grade 1 and grade 2. We did not see an important safety signal that was concerning for gilteritinib therapy in terms of serious frequent toxicities. And in general, gilteritinib therapy, being an oral tyrosine kinase inhibitor, was administered in the outpatient setting and was generally well tolerated on this study. So in conclusion, single-agent oral chemotherapy with gilteritinib, a targeted inhibitor of FLT3, improves both response and survival of patients with FLT3-mutated relapsed and refractory AML. This is a major change in how we approach patients in the relapsed refractory setting, because now we're using molecularly targeted therapy to select patients that can benefit from this approach. And we've shown that a lower toxicity agent, more or less comparable to the low-intensity approaches, can outperform the general fallback of using standard toxic chemotherapy that requires inpatient hospital stay. This is a practice-changing result, and we think establishes a new standard of care for this population. Thank you for your attention.